So, hello everybody. I am Dr. Mark Komrad. Many of you at Harvest of Hope may know me, have seen me before. I've had the privilege of being with you all for 4 or 5 years. I think I missed 1 or 2 years. I've been there in various ways as a keynote speaker, and every year I do what I am doing now, which is an Ask the Doctor session, which I like to refer to as everything you've ever wanted to ask a psychiatrist, but never had the time. Because, we psychiatrists, we still are some of the few physicians that work by the clock. And very often there's not enough time to get all of your questions answered, whether you're a patient or a family member. Sometimes family members don't have access to talking to the psychiatrist. So I am here this evening to do what I love to do every year with Harvest of Hope, which is to try to answer your questions. And we can talk about any one of a variety of things. You can, type your questions, I think, into this chat box. I'm sorry that we can't be together as we usually do, and I can look into your eyes and dance all around the room as I like to do, as some of you have known me before. But instead, we're in this difficult passage, time that's very challenging, maybe for some of us, one of the most challenging passages of our lives. But we have developed technology, ways of working around, and I am still here to be able to answer your questions. Now, there are a couple of things that, while we're waiting for questions, I'll just tell you a little bit about myself. And how it is that I came to actually be doing things like this. I am a practicing psychiatrist of 35 years now. My work for many years was involving inpatient work, doing work with people with major mental illnesses, particularly schizophrenia. I helped to run the treatment-resistant psychosis disorders unit at Sheppard Pratt in Baltimore, Maryland. And I also have always had an outpatient practice. In the last 10 or 15 years, I've done exclusively outpatient work. And my practice really is to combine psychotherapy with psychopharmacology. So I'm kind of a one-stop shopping kind of psychiatrist, so that people come to me both for talk therapy and medication management. Sometimes I do collaborate with other therapists who I see patients, they see the patients as well. So I'm used to that kind of collaboration a little bit as well, although most of my practice, I'm seeing people as their only mental health professional, if not the main mental health professional. I also have another hat that I wear. I am a medical ethicist, and I have been very active worldwide, as a matter of fact, in issues of psychiatric ethics. We can talk about some of those kinds of things. Also, I'm very active in the media. As my biography will tell you, in preparation for this, I have been the host of a radio talk show that went coast to coast for many years, called actually Komrad on Call. And it was a live talk show where people could call in and ask questions. Sometimes I interviewed colleagues about specific topics, but often would take open-ended questions to do actually very much what we're doing tonight. In many ways, this kind of reminds me of my open phones hours that I had in my show, where people could call in and ask me any questions, and covering topics from the most scientific topics about the brain, about treatments, about medications, about talk therapies, to more systems issues about the mental health systems, insurances, hospitalizations, involuntary commitment and treatment. It's interesting, one of the most common questions that I got asked was the questions about people would often call and ask me, I have a loved one, a sister, a cousin, a grandmother, a child, a husband, who clearly needs more help than I have the ability to give them. How do I convince them to see someone like you? So I brainstormed with people on the air for several years, and that actually developed a special interest in my practice where people would come to consult me actually from around the nation about how to convince their loved ones to get at least an evaluation from a mental health professional, especially from a psychiatrist. And after many years of doing those consultations, I put that into a book. And that book is called You Need Help, a step-by-step plan to convince a loved one to get counseling. And by the way, in it, I think I once did a literature search and found that I had mentioned as one of my most important tools that I use in my work is NAMI, referring people to NAMI. I think I mentioned in the book, I mentioned NAMI 23 times in the book. So what I'm going to do is I'm going to type here into the chat the website where you can find out more about the book if you're interested. NAMI actually uses it in many of the family-to-family courses. And it's, again, called You Need Help. The website is youneedhelpbook.com. So I'm putting that in the chat. I don't know if you all can see the chat. I think everybody has access to the chat, and you can see the website there. All right, so enough introductions, and let me get to some of the questions. And I'm trying to kind of figure out in which directions the questions go, from the bottom up or the top down. I'll try to get them all. All right, well, the first thing that I can see is Michael's question: what are the side effects of lithium? So lithium, which is, by the way, one of our most studied medications in psychiatry. It's been around for so many years. There have been literally thousands of papers written about it. Other medications that are sometimes used in place of lithium, instead of lithium, have not been around as long, have not been as extensively studied. So we know a great deal about lithium. And so we know a lot about how lithium might work, what are its side effects, and how to use it. By the way, one of the great advantages of using lithium, I want to say, is that of all the different medications for that use, which is primarily in mood disorders, particularly bipolar disorders as a mood stabilizing medication, that of all the medications, lithium is the one that we really have the most reliable data about how much to use in any given patient. And that's determined by a blood level. We actually measure the amount of lithium in the bloodstream so that we can adjust the dose to get that blood level in just the right therapeutic range. None of the other medications, like you may be familiar with some of them, Depakote, Tegretol, Trileptal, Lamictal, none of those other medications do we have reliable scientific evidence about what the blood level should be to optimize the effect, particularly for the treatment for bipolar disorder, to provide mood stabilization. So now to the question, because I'll always give some contexts and maybe additional information for each question. Some of the common side effects of lithium are increased thirst, increased urination, tremors, very small, fine, shaking tremors, sometimes nausea, sometimes diarrhea. Most of these common side effects actually are related to the dose, or actually the amount that's in the bloodstream. So they tend to occur at higher doses. There are other side effects that generally one picks up first on laboratory testing. And it may manifest itself as abnormal laboratories before it manifests as a clinical problem. So one might see early signs of abnormal thyroid functions on blood tests, abnormal calcium on blood tests, and effects on electrolytes on blood tests. Those are common things in people who are on lithium we want to follow, and kidney function tests. So every 6 to 12 months, we want to check in on kidney tests, calcium, thyroid. Those are the electrolytes. Those are the common things that we look for because lithium can affect those things. And if it starts to affect those things, we can actually address some of those problems as well. All right, so I could go on and on about lithium, but I think that at least covers the basic question. What are the side effects of lithium? All right, next question from Kenneth. Are there any objective tests for mental illness? This is actually one of my favorite questions because I think it's a very, very important one, Kenneth. The fact of the matter is that psychiatry at this point is largely what we call a phenomenological science. That is, our illness constructs are based primarily on the phenomena of the signs and symptoms of mental illness, the disruptions that it causes in mental life. And remember, mental life has 3 domains. The domains of mental life are thoughts, feelings, and behaviors. And so all the disorders that we treat in psychiatry affect one or more of these 3 areas: thoughts, feelings, and behaviors. And based on the patterns, the way in which they unfold over time, and the assortment of these various disruptions in those 3 domains, we have come to identify certain constructs of illness. But we do not, in psychiatry, have another domain in which we can validate these constructions of our illness ideas like schizophrenia or bipolar disorder or PTSD and so forth. There are no reliable, consistent domains. So for example, if you go into the emergency room with chest pain, the question is, are you having a heart attack or a myocardial infarction, which is the medical term for a heart attack? Because chest pain can be a lot of things, right? It can be some acid reflux. It can be some inflammation of your cartilage, around the bones, around your sternum. It can be esophageal cancer. It could be a lot of things. But is it a heart attack? Well, we ask a lot of questions about the clinical presentations. Where's the chest pain? Is it radiating down the arm? Are you sweating? Are you nauseated? Do you have pain in your jaw? And so forth, which can certainly suggest that you might be having a heart attack. But we can go to another domain in order to be able to then verify whether in fact it is a heart attack. So we can get an electrocardiogram, an EKG, and see characteristic waveforms on the EKG that we see in the presence of a heart attack, a myocardial infarction, which is where a little piece of the heart tissue is dying. And because when a piece of the heart tissue dies, it releases certain enzymes, we can do blood tests so that we can measure whether there's been a spike in those enzymes that have been released from the tissue that's not being well oxygenated in your heart. So we can couple the clinical information of the symptoms that you've described to us with a blood test and an EKG. And based on the blood test and EKG, we can come back with the answer to the question, are you or are you not having a heart attack? We don't have to rely on the symptoms alone. There is no similar thing for psychiatry. We do not have a blood test, an imaging test, a brainwave test that we go to in order to definitively tell you, yes, you have schizophrenia. No, you don't have bipolar disorder. Yes, this is a panic attack. We rely strictly on the clinical information that you give about the experiences you are having in the domains of thoughts, feelings, and behaviors. Now, we know that we can sometimes see disruptions that appear in certain tests of brain function, or tests that sometimes that we can do blood tests for and so forth. But those changes are not unique to those diagnostic constructs. So that means that you might be able to take somebody with bipolar disorder and do an electroencephalogram and see some changes in their brain waves during a manic episode. But those changes are not unique to a manic episode. So you can't diagnose a manic episode because those changes have occurred, because those changes can occur in other conditions as well. So they're correlated, more likely to be found in this certain illness. They cannot be used diagnostically. And this is very important because this is the state of the art of, we're always looking for what are called biological markers that we can use to begin to sort out the different illnesses and predict also who's going to respond to which kind of treatments. And there's interesting, tantalizing information about that that has been accumulated, but is really not ready for prime time. But I want to warn you that there are some practitioners that want to sell you very high-priced tests that they claim should be administered in order to flesh out the proper psychiatric diagnosis, that are often, not covered by insurance, that are many, many thousands of dollars, that they go put up the pictures and the results and say, see here and see here and see there. This is schizophrenia. Okay. I'm sorry, ladies and gentlemen, that is not so. Those practitioners are not practicing at the acceptable level of the state of the art. They are taking research findings that really have not been shown to be reliably useful for that kind of diagnostic process. And you are paying unnecessarily for something that sure looks impressive, as if it is, a really, state-of-the-art neuroscience. But it just, as my uncle used to say, it just ain't so. All right, so I think that's enough on Kenneth's excellent question. All right, next let's go for the question is next from Guru. Any effective medications for bipolar disorder without the side effect of weight gain? Good question. So this is actually one of the problems with many of our psychiatric medications is weight gain. As we develop new medications for all the conditions, as new medications are developed, increasingly that has to be one of the side effects that you've got to beat if you're going to bring a new medication to market, because there's already enough out there, and this is a big reason why people sometimes don't adhere to the medications or are afraid of taking medications, is their concern about weight gain. So the good news is we've made some progress about that, and there are some medications that have been developed that are less likely to produce weight gain, which means that future medications have got to do even better than that. So for bipolar disorder, obviously we spoke before about lithium, and lithium is the mainstay and the most well-studied medication. As I told you, there have been thousands of papers about lithium, but lithium does have weight gain as a significant side effect, which I don't remember whether I listed that when I was talking about the side effects of lithium, but there you are on, back to that question. Weight gain is a very common side effect with lithium. Not everybody gets it, but it is pretty common. Similarly, the second most common medication that is used for the treatment of bipolar disorder is Depakote, or valproic acid. And weight gain is, in fact, a side effect of Depakote. A little bit less so than lithium, so that was a bit of an improvement, but it still can be a significant problem. Additional mood stabilizers that are used for bipolar disorder, that are commonly used, have even less weight gain than Depakote. Specifically, Lamictal or lamotrigine has much less propensity to cause weight gain. And trileptal or oxcarbazepine and its relative Tegretol or carbamazepine have less tendency to cause weight gain as a side effect. Now, we're beginning to use more and more the so-called atypical antipsychotics for mood stabilization in bipolar disorder, not just for their antipsychotic effect, but as mood stabilizers. They come with some of their own problems. And for some of those, that's weight gain. Some of the actually most effective mood stabilizing atypical antipsychotics actually cause a lot of weight gain. The two most effective are Seroquel or quetiapine and Zyprexa, also known as olanzapine. I'm giving you the brand name and the generic name. Both of those are very effective mood stabilizers, and they can cause a great deal of weight gain. However, there are some newer medications in that same category that are being used now for mood stabilization that don't cause as much weight gain. Examples include Geodon, otherwise known as Ziprasidone, Latuda, otherwise known as Lorazepam, a brand new one called Vibrid, otherwise, I'm sorry, not Vibrid. Vibrid is actually an antidepressant. Now I'm having a mental block. It's so new that I'm having a mental block. It begins with a V. It's not Vibrid. Vraylar, excuse me, Vraylar. Vraylar is a new atypical antipsychotic that we're using as a mood stabilizer, and it has probably, of all the medications that I've mentioned, least likely to cause weight gain. But I do want to warn you that the newer the medication, the less the evidence base for the efficacy of that medication in bipolar disorder. But it's certainly something to bring up with your doctor. Some of these newer atypical agents that I've spoken about, and things like lamotrigine or Lamictal. Okay, let's move on to the next question. Next question is from Grace. Are there particular mental health challenges that you've seen rising during this pandemic? And for those in the healing professions, have you noticed a particular fatigue in addressing mental illness through therapy over screens? So that is another great question. I think there are some very significant challenges. As a matter of fact, I gave an entire lecture on this to NAMI, Maryland, and it is available. And if people want to get in touch with me afterwards, I'll be glad to give you the link to the YouTube, which is a whole hour addressing this issue. But let me just mention a couple of things. First of all, I think that obviously for people that are not tech savvy, getting onto Zoom or things like this can be very difficult and very challenging. Those people are having to resort, at the height of the pandemic, have been having to resort to telephone evaluations, which have all sorts of limitations that I'm sure you understand. I think that it's been very difficult for inpatient work. Why? Because many inpatient units psychiatric units have had to take their inpatient rooms that have more than one bed in the room and collapse it down to single private rooms. So that means for many inpatient units, halving the census, the number of patients that they can take. So there was already a shortage of inpatient beds. But if you're now turning every room into a private room, you may be cutting your census, your ability to take patients, in half or even more. There's some inpatient units that had 3 people to a room or even more. So that's been a problem. And also with discharging people. The fact of the matter is that there's been a significant rollback in aftercare opportunities, particularly for step down after inpatient treatment, such as partial hospitalization in day hospitals. Many of them have been closed for a long time. Then they came back using Zoom, but because of the Zoom format, they're also limiting their number of patients that they can handle by Zoom. And frankly, when you have been so ill that you need to be in a hospital and now need, an intermediate level of care, day hospital, sitting at your home and, spending 6 hours a day or 5 hours a day on Zoom in a day hospital kind of format is not sustainable or feasible for many people. So those are just 2 examples, and there are many, many more. And if you want to hear my talk about other kinds of challenges that are coming up for people during this time, isolation, and some of the special challenges of dealing with psychosis at this time, and people's willingness to come to the emergency room, and so forth. Now, from the provider side, from my side of the screen, I think that there is. It's very challenging. Kind of gotten used to it. It's actually in a way easier than when we first started this to do Zoom kinds of calls and other platforms that we use. But it's, all we have is sort of from the neck up to see people. It's, limits the total body assessment. Many people, are very distracted when using it. They're in their bedrooms, or people walking by, they're, other relatives, and, sometimes nice things like get to see people's dogs and cats and other pets on Zoom. I actually personally enjoy that. Some people are, Zooming in the car. People don't often pay attention to their own image on the screen, so they get their heads cut off, or their side of their face, or I'm looking up at their ceiling and having to say you need to recenter yourself. It's difficult to have eye contact. It's very so it is actually there is Zoom fatigue on the side of practitioners. People are gradually. I right now am considering beginning to open up my practice a little bit. But frankly, my own screening process is not just going to be the usual questions, which is, if you had a fever, are you in direct contact with anybody that's tested positive? For patients to come to my office, which is actually a pretty open and well-ventilated place, I'm going to want to know things like, do you go to indoor restaurants? Do you go to church? Do you go to the gym? Do you go to bars? Do you use a mask? Have you been to large family reunions and weddings and funerals? These are all actually kind of known to be high risk activities and potentially super spreading events, as they're being called. So I'm going to start to have to sort of do a screening, and people that are not observing low risk behaviors, or they can't observe by virtue of their work, I'll probably have to continue to work with them on Zoom and not yet have them into my office until we have a much more robust treatment protocols for COVID, as well as not just an effective vaccine, but a vaccine that enough people are taking. to be able to create not just individual efficacy, but efficacy for the population at large. Okay, there's so much more I could say about that, but I'm going to move on from Grace's question next to Kenneth's questions. Actually, you know what? I'm going to skip Kenneth, if you don't mind, because I think we already answered a question of yours. I'm going to try to come back to those who are on their second round of questions, and I'm going to go on to Andrew. Andrew says, what are some of the distinguishing factors in your decisions to medicate or not medicate an individual? These are really great questions tonight, folks. This is really a very poignant question. So, you know, there are many things that go into the decision to medicate and not medicate. First and foremost, I would start with thinking about, I'd start with the issue of severity, okay? Because, well, no, let's not start there. Let's start with the issue of what I think is the nature of the problem, okay? Because the thing is that not every problem that walks into a psychiatrist's office or any other mental health professional, for that matter, is something that is best understood as a disease, as something that has to do with a biologically based abnormality in the functioning of the brain. Some things are best construed as diseases, as something malfunctioning, a broken part in the we'll call it the neurophysiology of the brain, okay? And examples of that might be schizophrenia, schizoaffective disorder, a manic episode, a major depressive episode, a panic disorder. Those are things that might be best construed as diseases, okay? But not everything is a disease. There are other kinds of construals about the kinds of problems that walk into our office from people who are experiencing suffering in the domain of their mental lives, right? So some things may be best understood not as broken neurophysiology, but as disorders of dimensions, namely where, you know, we all have traits, right? And, you know, we have some of those traits are physical, like how much we weigh and how tall we are. Some of those traits are psychological, how well we pay attention, how sensitive are we to criticism and rejection, how comfortable are we in crowds, how easy is it for us to read other people's emotions. And all these things, think of them as sliders that slide around, right? And we're all born with our sliders set to various levels on these different sliding scales, these different dimensions. And sometimes by virtue of how your dimensions are set, when you live in a world that is not set for those dimensions, but set for maybe more average dimensions, you may have problems adapting. I mean, think about somebody who's 7 feet tall in a world where all the door frames are 6 feet tall. That person is going to get hit on the head a lot unless they learn to stoop. Or somebody who has a very, very high weight, who sits in a theater seat or an airplane seat that's designed for, you know, people in the range of more average weights. Okay, so these are not necessarily diseases, but people who, by virtue of their dimensions of how they are built as a result of nature and nurture, are prone to have problems adapting to functioning in certain contexts in the world around them. Those are not diseases. And then there are other problems so the examples of those things might be, for example, personality disorders would be an example, or people who have intellectual problems with, you know, their IQ and may be mismatched in a setting where they need a different IQ than they have and are having a great deal of distress as a result of that. Then there are other problems that are much more better understood psychologically from the narrative of a person's life story, right? So growing up with an alcoholic father who frequently lost his temper and would sometimes beat you and was highly critical, that person may very well come to me with having difficulty with intimate relationships or problems with authority figures. That's not a disease. That's not due to a broken part. That's not due to something wrong with the neurophysiology. That's something where we need to understand things meaningfully and delve into the person's life story and to see how problems are emergent from experiences that have meaning in the way human beings have meaning. You know, when you have a broken neurocircuitry, that's, you know, that could occur in an animal, right? But having a problem with an authority figure because you didn't trust your primal authority figure, that's not something that an animal necessarily would be able to have. So in the latter example, I would not necessarily be thinking about a medication. Whereas in the example of something that I am construing as a disease, I may want to dip into what the state of the art of psychopharmacology has to offer about that. So what is the nature of the problem? How I understood it, what perspective creates the best construal of this? Is it a disease? Is it a dimensional problem? Is it a learned behavior? In which case I may want to use some behavioral techniques to retrain and relearn. Or is it something that emerges meaningfully from a person's life story, in which case we may want to start talking about that person's life story and what are some of the legacies of the past and what are some of the ways that they may be responding in the present to a problem that really is more about how they learn to respond to something in the past. So those are, there's, again, much more that I could say about that, but I think that those are just a beginning of helping you understand how a psychiatrist thinks, how we begin to navigate with the information that's presented to us, whether or not we're looking for a psychopharmacologic solution or a non-psychopharmacologic solution, let's just call all the rest. And I really want to point out that it's not an either-or situation. As I said to you at the beginning of this, I have a practice in which I do both other kinds of therapies and medications. Some people, many people, I would say most patients, I'm doing both. Occasionally, I'm just doing meds, and we talk a little bit about other things. And for some people, I do just talk therapies and don't have on medications. But there are many conditions where we really understand that the two together, psychotherapies of various types and medication, work together in such a way that they are more than the sum of the parts. You know, so it's not 2 + 3 = 5, it's 2 × 3 = 6. And there's a great deal of scientific research to actually demonstrate that when you use both modalities together, the outcomes are better and quicker. And that's very important. And frankly, it's one of the reasons why I believe that, and it's not always possible, but I often recommend to people that as they look to have an evaluation and to seek treatment, that I believe that it's best to start with a psychiatrist. You may not end there, but to start with a psychiatrist, not as opposed to other kinds of mental health professionals. Why? Because first of all, we have the largest breadth of clinical experience and understanding about all the various ways things can go wrong in mental life, including the ways that mental life can be affected by many, many other medical conditions. I mentioned thyroid before, and kidney and liver and so forth can produce problems in mental life. You want to make sure that's not what it is that's causing the problem. So diagnostically, there's a greater breadth of experience. And therapeutically, we have at our disposal both state-of-the-art neuroscience psychopharmacology and other modalities, which we may get into with some questions like transcranial magnetic stimulation and electroconvulsive therapy and some of the newer chemistry treatments such as ketamine and now emerging psychedelics and so forth. And we're taught to do psychotherapy so that we can bring these combined hybrids of multiple different kinds of treatment together that become more than the sum of the parts. Okay, I think I over-answered Andrew's question there. All right, now we have Michael. I'm actually going to, I don't know if Michael's asked the question before. Let me see what else we've got here. Kenneth, does smoking marijuana really help with bipolar 1 disorder? No, does not. Significant evidence shows that the cannabinoids, especially the THC that are active in marijuana, make bipolar disorder worse. I'm going to lean in close for this one. Make bipolar disorder worse. The evidence base is not only clear that if you have bipolar disorder, smoking marijuana destabilizes it, but there's even some evidence, ladies and gentlemen, that if you have a genetic vulnerability to bipolar disorder or schizophrenia, that habitual marijuana use, whether by smoking or by edibles, may actually precipitate, bring out bipolar disorder and schizophrenia. So I really want you to understand that the emergence of medical marijuana is not based on the standards of the kinds of state-of-the-art science that we use, for example, to develop any other new prescription medication. It is not. That this is an instance in which politics and, frankly, economics is leading the marketplace and has bypassed all of the usual science and safeguards that go into developing medical treatments in order to push things out there. Many people actually see it as perhaps a felicitous way of opening the gates for legalization. And that's something, that I don't really want to get into. I'm much more interested in the clinical issues. And I will tell you that the evidence that marijuana is helpful for bipolar disorder, schizophrenia, even anxiety disorder is not only not there, but in fact, the evidence that is there is often to the contrary. And so medical marijuana is not available to you because there is scientific evidence to support its value in psychiatric disorders. That evidence does not exist and indeed may be to the contrary. So that's all I'm going to say about that. All right, now we're going to go to George. Our son, who is 31, had a psychotic break at medical school in a medical school interview in 2016. He relives the interview every day, believes he's being mentally tortured, and was going to be killed by one of the other school applicants who said he was with the CIA. He sees a psychiatrist, but gets upset every time he has an appointment, and he says the doctor cannot help. He was taking Abilify 10 milligrams, bupropion 150, temazepam 50, prazosin 6, and clonazepam as needed. He believes he has PTSD, and the school and the other person inflicted a synthetic schizophrenia on him. He stopped taking the Abilify and bupropion. Okay, this is very, very long. He does not believe a psychiatrist can help, wants to sue the school. We recently convinced him to restart Abilify, but the hallucinations and angers are lived every day. What advice can you give us? Well, I can't, standing on one foot, really give you a great deal of intelligent advice about this specific case, but let me make a couple of principles that may come out of this, okay? So first of all, certainly what you describe has the appearance of somebody who clearly has had enduring psychotic symptoms, enduring paranoia, and enduring delusional system. And for many, unfortunately, one of the things that we know about many chronic, persistent psychotic disorders, schizophrenia, schizoaffective disorder, most typical constructs, we know that these illnesses often come with an inability to have insight into the fact that they are ill. And it's very interesting because I have, I would say 80% of patients have this. Matter of fact, it goes by a fancy Greek term, which I always love to give out every year. I write it on the blackboard, anosognosia, anosognosia, which is Greek for they don't know that they don't know. Anosognosia. And it's interesting because very often that leads to people not wanting to take treatments. Or sometimes what it leads to is people willing to take the treatments, but not willing to accept that they have a psychosis. So they'll come up with other things. I have PTSD, or, this is just, I'm just depressed, or I'm just anxious, or, I'm trying to deal with a poison, that it is continuing to be administered to me by the CIA or something, yeah, and they'll even say, yes, I understand there's such a thing as psychosis, and I understand that people have schizophrenia and schizophrenia have delusions, but that doesn't apply to me. That's not me. I'm different, and this is actually, sadly, this is actually rather common. Okay, so I want to say that. Okay, now what's also common is people who have tried antipsychotic medication and haven't gotten particularly good results with antipsychotics like Abilify, right? And as we see here, he took Abilify 10 milligrams. Well, so when you're not getting good results with an antipsychotic, one of the questions is, number one, are people compliant with it? Okay. And for those who are not consistently compliant with taking pills, we have a number of antipsychotic medications that can be administered by long-acting injection. By long-acting, I mean you need an injection only every 2 weeks, some of them even every 4 weeks, so that it's not a matter of, am I going to take the pill today or not? Did he take his medicine today or not? And many people who are not adherent to a medication regimen, and that's why they're not getting more optimal results, they tend to do a lot better when you get them on long-acting injectable medications. And by the way, Abilify has a long-acting injectable version that you can give between every 2 and every 4 weeks. So that's a thing to consider. Or if they are compliant with medications, for some people, it takes higher doses. That may be due to different metabolisms. It may be due to interferences with other medications that may speed up the metabolism. I will tell you that 10 milligrams of Abilify is hardly the maximal dose. I've used, 20, even 30 milligrams of Abilify in some patients, and that's what it took to get them better. Now, obviously, these things are limited. If there are side effects, some people can't tolerate the higher doses. And then finally, I want to say that, and I always look for an opportunity every year to make mention of this, that they're actually not all antipsychotics are equally effective. Specifically, what I'm meaning is there is actually one antipsychotic that we know is actually more effective than all of the other ones. It stands out. It's a standout in its efficacy. And that medication is called clozapine. The old brand name was Clozaril, but it's generic now, so it's clozapine. And clozapine is not used frequently enough, but it should be. and it's usually not something we go to as the first choice. Why? Why not use it for everybody? It's tough to use. It has some challenging side effects. Weight gain, for example, is a big one, and it has a rare side effect, which is causing people's white blood cell count to drop in a dangerous way that makes them immunocompromised. It's very rare, but the FDA requires to take this medicine that the patient have a blood test to check their white blood cell count every single week for the first 6 months, every other week for the second 6 months, and then after a year, once a month, indefinitely. And so people have to be willing to get the blood test and cooperate with that. And doctors have to be willing to follow up with the blood tests and monitor it. And the drug cannot be dispensed at the pharmacy until the pharmacist sees the result of the blood test. No blood, no drug, to make sure that the white count is okay. So it's got some logistic problems, but when people fail to respond to other medications like Abilify, Zyprexa and Seroquel and the old ones, Haldol and so forth, very often you get a much more robust and complete response from clozapine. So this was my opportunity to bring out clozapine, and that's something for George and family to consider. All right, next is from Barbara. And by the way, although we're officially supposed to go an hour, I asked for an extra half an hour, and I thought I'd keep answering questions until 9:30. So I'm working my way through these questions, and as long as you guys keep asking them, I'll be here till 9:30. For those of you that want to duck out and see Harris and Pence, believe me, I understand. They'll have much more influence on your life than I don't know, maybe. All right, so Barbara says, last night, Dr. Susan McElroy talked about lumateperone, which is Caplyta, as an approved second-generation antipsychotic for schizophrenia. She said it has minimal side effects such as weight gain. When will this be approved for bipolar disorder? She also mentioned liraglutide as a possible treatment for obesity. Yes. Not sure if it's approved. What can we do for our loved ones who are neuroleptics to become obese? So this goes back to some earlier questions about obesity. And again, as I remind you, I told you there were some medications that are less likely to cause obesity. The liraglutide is actually now approved for treatment for obesity. That actually is approved. It's actually an injectable medication that you have to take every day. So that's a little bit challenging. And you can imagine some people with psychosis, that may prove an issue, having to get an injection or give themselves an injection like a diabetic on a daily basis. That is approved. I don't know when Caplyta is going to be approved. I guess it's interesting. I didn't even realize that it was approved for schizophrenia. It's approved for postpartum depression. It's very, very expensive. And I do not expect that insurance companies are going to have that on the list anytime soon. With regard to whether it's approved for bipolar disorder, let me just say that something does not have to be officially FDA approved for us to use it. In fact, most of the, not most, but I would say a large majority of the treatments that we use in psychiatry are not FDA approved for that indication. For example, Depakote for bipolar disorder, never been approved. Tegretol, never been approved. Trileptal, never been approved for bipolar disorder, but we use it all the time. Gabapentin for anxiety, never been approved for anxiety, but we use it all the time. So once a medication is out there on the market, physicians are free to use it as their clinical judgment dictates. So we, on the prescriber side, don't have to be constrained by it. Now, are you going out on a limb? Well, you are kind of going out on a limb a little bit, but if there is some evidence base, case reports, or a research study that has shown that something can be useful in a condition, that's good evidence that one might want to say, especially if things that are more recognized and more conventional aren't working. That can make me feel comfortable using something that's off-label, as the saying goes. The big issue of being on-label or off-label is how likely are insurance companies to cover it. And sometimes you can get insurance company to give prior authorization for something that's off-label, but oftentimes they'll want some scientific evidence that you've got something to back you up as to why they should approve this expensive medication like Caplyta in schizophrenia or bipolar disorder is what you're asking about. So that you can show that, well, I'm not the first person in the world to try this out. So that's what I have to say in answer to that question. All right, now we're going to go to Michael, who asks, could you please speak about the relationship between conscious and subconscious thinking and strategies for someone with mental illness can use the subconscious and conscious aspects to deal effectively with mental illness and increase positive outcomes as well as increase confidence? Well, I do, as a psychiatrist, it was Sigmund Freud who kind of put the idea of the unconscious on the map. And I think that there are few things that Freud did that we can still appreciate and celebrate and have stood the test of time. And I think that there's good, ample scientific evidence that there is an unconscious, which is the part of the mind that is outside the direct access of conscious awareness, that can be very determinant of your behavior. But the interesting thing is, one of the things that Freud really was trying to achieve, and he said it very literally, he said that the job of his technique, which was psychoanalysis, the job was to make the unconscious conscious, right? And in many ways, the legacy of that, which we call psychodynamic psychotherapy, are techniques that are designed to help explore the unconscious and begin to make some of the assumptions and conclusions and ways of seeing the world that are more characteristic of that less accessible part of the mind, the subconscious or unconscious. Those terms are used interchangeably, by the way, to be able to bring them out and make them conscious. But to do that, you may have to get around certain blocks that interfere with the accessing of the unconscious, because it's a very vulnerable place, and there are often a lot of painful ideas that exist in the unconscious. And we develop what are called defenses or defense mechanisms that resist looking into the unconscious. So many forms of psychotherapy are really designed to try to get around those blockades, those resistances that come with the defense mechanisms. So really, I think the approach to dealing with these is to use the kinds of psychotherapies that are called psychodynamic psychotherapies. Now, this does not necessarily mean traditional psychoanalysis that sometimes can go on for years, sometimes interminable, as Woody Allen has caricaturized and actually had interminable psychoanalysis himself. There are shorter versions, short-term dynamic psychotherapies that really are just several months, sometimes even just 5 to 10 sessions, that begin to approach some of these defense mechanisms and try to get at the mobilization of the unconscious to empower a person by not having things remain in the unconscious. So that's what I have to say about that. All right, now we're going to move on to Cliff. Cliff says, I've been treated in the past for schizoaffective disorder and have a long history of the mental health system, yet have recovered much. It's great and stable and working. It's good news. I've seen a lot in my travels, and the most disconcerting thing I saw as a late 20 to 30-year-old person given antipsychotics for being emotional and crying a lot. To me, his roommate, he seemed fine before the meds. When he was given meds, he became angry and distorted. I think this was mistreatment, and it happened 13 years ago in a state hospital in New Jersey. Are there any interventions that seem so inhuman? I'm not so sure. Are there any interventions that seem so inhuman? Look, I don't know, how long ago this was, but look, the fact of the matter is that there are appropriate and inappropriate uses of every medication, whether it's antipsychotics, stimulants, benzodiazepines, all of them. There's appropriate context for them and inappropriate context for them. There are ways of using them that where they're not indicated and they're used, or where they are indicated but they're used in too high a dose or used for too long a time, right? So, certainly there are many, in all fields of medicine, there are misapplications and there are misadventures. Now, certainly there are times that people use antipsychotics acutely, not necessarily for an acute psychosis. Sometimes they're used for people who are very acutely agitated. And when people are acutely agitated, the appropriate use of those is not merely to get them to feel better. It's to use that if that agitation is putting themselves or others at risk. Head banging against the wall, smashing things in the room, becoming, aggressive and violent towards others, trying to, cut or hit the self in a state of acute agitation. And sometimes the stronger medications that are very sedating, that are sometimes used primarily in psychosis, can be used in an acute setting for a short term to be able to de-escalate a situation in the interest of a person's safety or the safety of people around them. But look, that has to be done judiciously, thoughtfully, compassionately, with as much explanation as possible for the briefest period of time. Are there some institutions that have a higher standard of excellence than others? Yes, there are. And does the range of those standards vary? Yes. And in psychiatry, does it vary more widely than, say, in neurology or orthopedics or surgery? And I honestly have to admit that yes, that the breadth of, I'll use a positive term, the breadth of excellence is much wider in the world of psychiatry, both in the outpatient domain, but especially in the inpatient domain. One of the reasons is that we have a two-tiered mental health system, right? We have a private mental health system and a public mental health system. And there are certainly there's excellence in both areas, but the public mental health system tends to be more poorly funded. It tends to not necessarily, in some places, this isn't true in all places, certainly not true in my state of Maryland, it can't attract the practitioners of the highest levels of excellence because of the salaries, that they pay. Maryland, I do want to say, pays excellent salaries and can attract actually some of the best people in the public domain, especially in the state mental health system. So this whole idea of state hospitals, why are we still, I know I'm preaching to the choir here, but why are we still living in a world where we have state hospitals for psychiatric disorders? We don't have state hospitals for orthopedic disorders or cancer or for pediatrics. Why in the world do we have to have a whole separate state-funded system that is not necessarily associated with academic institutions and state-of-the-art research facilities and so forth, but oftentimes very far removed, way out in the country, a legacy of the last couple of centuries of mental health care? Why do we still have state hospitals? That's a bigger question than I'm prepared to answer. It's a rhetorical question. Again, I know I'm preaching to the choir, and I also know that state hospitals are not the only site where people sometimes get inappropriate treatment. So I don't want to leave you with that idea. All right, I'm looking for other questioners here that I think we may be on to the second round here. I think maybe we've already heard from Barbara. I'm just seeing familiar names here. Barbara, I think, already asked a question, but I think all the people that I see here are repeats. So why do most psychiatrists only give a 20-minute medication review rather than the model you use? Excellent question. And I will tell you that there are probably several reasons, but I'm going to discuss the most important reason. Okay, the most important reason is, I don't know, that's not fair for me to say the most important reason. An important reason is that most of the psychiatrists who do a 20-minute medication review take your insurance. So why do they just do a 20-minute medication review? They do that because the insurance doesn't pay them enough to sit with you for an hour. The meager amount that their insurance pays for that 20 minutes puts the psychiatrist in a position where they have to see 3 people in the course of an hour rather than 2 if they're in private practice. And if they are in a clinic, the clinic doesn't get paid enough for them to have enough psychiatrists to sit for a half an hour or an hour with patients. It pays them enough to have a lower level, lesser trained mental health professional like a social worker or a counselor sit with the patient for 50 minutes and to have a 10-minute or 15-minute visit with the psychiatrist every 4 or 5 times so that the psychiatrist can see 30 people in the course of a day, right? And you get, a lot more bang for your buck, 30 minutes, 30 people in the course of the day. Now, one might say that in the setting of scarce resources, and psychiatrists are scarce resources, one might say that a 20-minute visit with a psychiatrist is absolutely better than no visit with a psychiatrist at all. And I definitely believe that. Just a medication check from a psychiatrist and then sending them down the street or down the hall to a social worker is absolutely better than no treatment at all. And that if you're a scarce resource as a psychiatrist, that having that doctor be able to see 30 people in the course of a day may actually be a very efficient use of a scarce resource, as opposed to me, where I see between 7 and 10 people in the course of a day. Because I do have some half-hour visits as well. They're not all hour-long visits, but I don't have anything less than a half an hour. So I have a half an hour or an hour. Or to have a psychiatrist do an intake where they can see 15, 20 new patients in a month by doing a 45-minute intake. Well, that would be an efficient use of time. When you come see me for an intake, my intake is 2.5 to 3 hours. And, it's quite extensive. And I review all sorts of past records, and I get outside informants. And by the way, I generate a written report that's between 8 and 15 pages long, which summarizes the comprehensive history as well as all of my diagnostic thinking about it. It's a document that patient has to follow them through the rest of their lives as long as they continue to be involved with mental health professionals. It's kind of becomes a very definitive document. And one might say, wow, that's great. That's wonderful. Isn't that really fantastic that you're doing that? Well, let me tell you something. That's nice, and it's great for the patients that I see and the patients that I see, but I don't take insurance. It's extremely expensive, that 3 hours, plus the additional couple of hours that I spend on the report. It's really a 5-hour exercise for me when I do an initial evaluation, all told, between the time I'm with the patient and the time that I'm writing. It's very expensive. Not a lot of people can afford that. And frankly, I think of all the people I'm not serving by virtue of practicing that way. Now, frankly, I've paid my dues. I've worked in clinics. I've run inpatient units. I've been, in other situations where I've had high throughput opportunities to care for a lot of people a lot of time. And I reached the point in my career that I decided how I want to practice psychiatry and doing it my way with the method that I want to use has been, very, very, very helpful to me. So I think that's some attempt to answer that question. Guru, another question. Is entry into the mental health system one way with no exit, or can someone completely come off psychiatric medications completely? Good question. And the answer is sometimes, right? I mean, we treat a lot of disorders that have a beginning, a middle, and an end to the treatment. But we also treat a lot of chronic disorders. Just like someone with diabetes, type 1 diabetes will continue to see their endocrinologist for the rest of their lives. Someone with emphysema will continue to see their pulmonologist for the rest of their lives. Whereas somebody who has cancer, for example, might have a course of treatment and do very well and have a remission, and may not come back for 15 years, if ever again, after seeing that. So there are some people that we treat for a short term, some people for an intermediate term, and other people have chronic and persistent illnesses that will need lifelong medication to manage. Hypertension, there are many people that stay on hypertensives the rest of their lives, or stay on Lipitor for the rest of their lives, or insulin for the rest of their lives, and will always need a relationship with a physician to continue to monitor and manage that. And there are some people who, even by virtue of their psychological challenges, continue to have ongoing challenges that continue to cause them distress, or put them in a position to cause the people around them distress, and get into various dysfunctions in various contexts where they may be. And I've had some patients who have continued to have talk therapy with me for, at this point in my career, over 2 decades. Now, I'm not seeing them every week, okay? I may see them once a month at this point. Or some of them, they come and go. Things happen, they come in for a series of sessions, then they disappear, but they know they got a phone, they've got a psychiatrist, they can always come back to see me when new things happen, different points in their lives. They get married, they become a parent, their spouse gets sick, their parent dies, I've seen people now, I've been in practice long enough to see people at various junctures and crises that come up in the course of different phases in the life cycle. So that's my answer to Guru. Now, Michael, who's asked a question before, asks another one: how to help a person get around what they do not know and begin to get treatment. Well, we're kind of coming to the end of our time, but this actually speaks to my book. The answer to this, I've written in an entire book to answer this question, which again is You Need Help, a step-by-step plan to convince a loved one to get counseling. And it starts with some of the most ordinary conversations and techniques, when to approach somebody, how to approach somebody, when not to approach somebody, what to be able to bring up in expressing your worries, what not to say when expressing your worries, how to utilize the art of persuasion to try to convince them to get, and the whole purpose of the book, by the way, is getting them in for that first appointment for an initial evaluation, because then it becomes the responsibility of the person doing the evaluation to come to a conclusion, offer a treatment plan, and try to work with the person to accept the treatment and continue forward in the treatment. So the object of the book for the reader of the book, which is typically the family member or the friend, is to get them in the door for the first time. So, but the book then goes on, and in fact, in many ways, the heart and soul of the book is what happens if persuasion doesn't work. And then there we get into, rather than techniques of persuasion, we get into techniques, frankly, of coercion. And not coercion by doctors and not coercion by police and emergency rooms, although that is a later chapter in the book, but rather the use of often untapped power that exists within a family. Because families are a lot more powerful than they think. The power to utilize the privileges of family membership to help steer loved ones towards treatment. Because there are some times that persuasion is not enough, maybe because of the nature of the condition itself, that people are not accessible to being reasoned with. You know, to persuade somebody means that you have the legs of reason on which to stand. But there are many illnesses that interfere with the exercise of reason. And so you can't utilize reason as a means of persuasion. You may have to utilize other powers that are inherent in the families. The power which I make no bones about, calling it what it is, coercion, therapeutic coercion. And that actually is the very heart of my book. Typically, by the time people have picked up my book, they've often tried many of the persuasion techniques. So we get to the coercion techniques. And then if a family's capacity for coercion fails, then I go on to talk about how to mobilize other powers of the involuntary mental health treatment system and how to optimize the approach, how to get the most out of the system, how to really use what we have in the most effective way. I was involved throughout my career in many, unfortunately, it sometimes comes to this involuntary treatment situations in the emergency room, in inpatient units, with my own outpatients. So I have a lot of tips there about how to optimize those other powers outside the family, calling the authorities, what to say in the emergency room, how to interact with inpatient teams, what to say and how to appear in an involuntary commitment hearing on behalf of your loved one. All right, I think we've got time to, I'm just looking to see if there are any other things that I've missed. I think we have gone through all the presentations. Michael asked, what's the underlying cause of hoarding disorder? I think there are many causes of hoarding disorder. It's not one cause. It's really a complex disorder. Sometimes the cause is psychosis and delusional. Sometimes the cause has to do with anxiety. Sometimes the cause is best sorted with obsessive compulsive phenomena that have to do with the kinds of impairments in the lack of satiation. By satiation, that means, being able to scratch the itch and feel relief from the scratch. You're sated. I did the scratching and it helped. Well, in obsessive compulsive things, I did the checking. I did the arranging, but it still doesn't feel like I've really satisfied the feeling that I wanted to get out of doing that. It still doesn't look right. I'm still not convinced I actually turned off the stove. So that obsessive compulsive approach can also sometimes be useful in some cases for understanding people who say, I haven't collected enough string yet. I don't, that sense that, okay, I have enough rubber bands. I'll never need any more rubber bands than this. That feeling that I can stop now. I don't have the itch to scratch, the urge to collect more rubber bands. That's just one trivial example of hoarding, but you can imagine that magnified on a much greater scale. Okay, any other questions? We're down to our last 3 or 4 minutes. Somebody asked about my town and state. And I practice in a suburb of Baltimore called Towson, Maryland, which is, as I said, associated in Baltimore. I have a faculty association with Johns Hopkins, University of Maryland, and Shepherd Pratt. I also happen to be on the faculty of Tufts down in New Orleans as well. My faculty appointment at Tufts, I am involved down there with teaching medical ethics. So I go down there. I used to go down there in pre-COVID days a couple of times a year to teach the psychiatric residents seminars in ethics. I guess this year we'll be doing more of that on video conferencing. And speaking of video conferencing, we've come to the end of yet another great year of great questions from Harvest of Hope. I always appreciate an opportunity to share with you what I know. I'm sorry I'm not getting the feedback even of your faces that I get when we're together live, but I hope that my one-way energy has fulfilled your needs and that you got to have any questions answered. Oh, look, there's one more that popped up at the end. Dr. Komrad, do you have any early life experiences that drew you to this field? The answer to that actually is no, in the sense that, that you might be expecting. So I did not have mental illness in my family, and I did not suffer from mental illnesses of my own when I was young. But I was drawn into this because in college, I was a double major. I had a major in an area of the humanities, which is philosophy, and sciences, molecular biophysics and biochemistry. And to me, the best marriages of the humanities and science was in the profession of medicine in general and in the specialty of psychiatry in particular. But I will tell you that I have a child who has had extensive challenges with attention deficit disorder, anxiety, and depression, and has been very involved with psychiatric treatment throughout his childhood. So I've been, at least I've been able to have, and that's been actually very important to me and very informative and educational to me, because in that sense, I've been a family member, just like many of you, on the treatment side of the equation. All right. Thank you so much, all, and I wish you all the ability to navigate in these difficult times that are difficult for so many reasons. And for many of you, in addition to the usual things that the rest of the population is struggling with now, you have your illnesses to struggle with. So I wish you strength and courage, and I send the prayers of wisdom to your treaters and to you and your loved ones. Take good care, everybody.